Chapter 9, Palliative Care at End of Life. So, first thing, right off the bat, take a look at Table 9-1 for the goals of palliative care. Patients receiving curative and restorative health care should receive palliative care at the same time. Palliative care extends into periods of end-of-life care. Bereavement care follows the patient's death. Palliative care at the end of life originated in the 1960s as care and emotional support for the patient, family, and significant others during the terminal phases of serious life-limiting diseases. The older population is growing, in part due to the aging baby boomer generation. Chronic illness is debilitating, costly, and along with terminal illness can be a significant burden for caregivers. Patients just diagnosed with illness such as cancer, heart failure, COPD, dementia, or ESRD can benefit from implementation of palliative care. The interprofessional palliative care team includes physicians, nurses, social workers, pharmacists, chaplains, and others. Communication is important for optimal care. Patients may receive palliative care services in the home, long-term and acute care, and mental health facilities, rehab centers, and prisons. Many institutions have established interprofessional palliative and hospice care teams. Hospice is not a place, it's a concept of care. Hospice programs focus on symptom management, advanced care planning, spiritual care, family support, palliative rather than curative care, and quality rather than quantity of life. Palliative care often includes hospice care before or at the end of life. Palliative care is different in that it allows a person to simultaneously receive curative and palliative treatments, whereas hospice care is initiated only after the decision is made by the patient or a proxy not to pursue a cure. Distresses common at the end of life may be physical, emotional, and/or spiritual. More than 3/4 of hospice patients are over the age of 65. The majority are white. Most common diagnoses are cancer and heart disease. The median length of stay in a hospice program is currently 21 days. Like palliative care, hospice is provided under a variety of models and in a variety of locations: home, inpatient, acute and long-term care facilities, rehab centers. Hospice nurses play a pivotal role in coordination of the hospice team and the need for excellent teaching skills. The hospice team needs to have excellent teaching skills, compassion, flexibility, cultural competence, and adaptability. Some cultural and ethnic groups may underutilize hospice because of the lack of information about hospice services, desire to continue with curative therapies, and concerns about lack of minority hospice workers. Physicians may be reluctant to refer patients because sometimes they view a patient's decline as their personal failure. Some patients or families see it as giving up. You and the hospice team may need to collaborate with community partners to facilitate supportive services to meet everyday needs of the patient and family. Hospice services are covered by Medicare, Medicaid, and many private insurance agencies. To qualify, the patient must desire the services and agree in writing that only hospice care, not curative care, can be used to treat their illness. They can withdraw from the program at any time if their condition unexpectedly improves. Patients can receive care for other health problems that are not related to the terminal illness, but those services may not be covered by the hospice, Medicare, Medicaid, or by the patient's insurance company. Eligibility requires that 2 physicians certify that the patient's prognosis is terminal with less than 6 months to live. Recertification only requires 1 physician. Care may be provided for extended periods of treatment if the patient still meets enrollment criteria but lives past the expected 6-month survival expectation. If a patient's condition stabilizes, he or she could be discharged from hospice. So, our first question, the nurse explains to a patient with advanced cancer about the differences between hospice and palliative care. Which statement, if made by the patient, indicates that the teaching was effective? Go ahead and read the answers. And what do you think? The answer is C. Hospice care provides compassion, concern, and support for the dying. The emphasis of care at end of life is on symptom management, advanced care planning, spiritual care, and family support, including bereavement. Hospice care may be delivered in a variety of settings, including home, inpatient settings, and long-term care facilities. Let's go and talk about death. It occurs when all vital organs and body systems cease to function. It's irreversible cessation of cardiovascular, respiratory, and brain function. Technological developments in life support have led to questions about when death actually occurs. When the whole brain, the cortex, and the brainstem cease activity, or when function of the cortex alone stops. The American Academy of Neurology developed the diagnostic criteria that must be validated by a physician: coma or unresponsiveness, absence of brainstem reflexes, and apnea. Currently, legal and medical standards require that all brain function must cease for brain death to be pronounced and life support to be discontinued. In some states and under specific circumstances, registered nurses are legally permitted to pronounce death. Diagnosis of brain death is of particular importance when organ donation is an option. IOM defines end of life as the period of time during which an individual copes with declining health from a terminal illness or from the frailties associated with advanced age, even if death is not clearly imminent. Uncertainty about how close at hand the end is adds to the challenge of answering patient and family questions, including how much time is left. End-of-life care is EOL care is the term used for issues and services related to death and dying. EOL care focuses on physical and psychosocial needs for the patient and family. The nurse spends more time with patients near the end of life than they do with any other healthcare professionals. As death approaches, metabolism is reduced and the body gradually slows down until all functions end. When respiration ceases, the heart stops beating within a few minutes. Respiratory changes are common at the end of life. Respirations may be rapid or slow, shallow or irregular. Breath sounds may become wet and noisy, both audibly and on auscultation. Noisy, wet-sounding respirations, termed the death rattle or terminal secretions, are caused by mouth breathing and accumulation of mucus in the airways. Cheyenne-Stokes respirations is a pattern of breathing characterized by alternating periods of apnea and deep, rapid breathing. The physical manifestations of approaching death are listed in Table 9-2. The sense of touch is decreased first in the lower extremities because of circulatory alterations. Eyes look sunken and glazed. Modeling looks faintly purple and white, leopard skin. The skin cools first on lower then upper extremity and finally the torso, unless a fever is present. Kidney function and sphincter control diminish. Pain-relieving drugs can accelerate the loss of GI function. Jerking seen in patients on large amounts of opioids. Cardiovascular, you'll see the increased heart rate, irregular rhythm, decreased BP, delayed absorption of IM or S or sub-Q drugs. A variety of feelings and emotions affect the dying patient and the family at the end of life. Once again, refer to table 9-3. Most patients and families struggle with the terminal diagnosis and the realization that there is no cure. Patient and family may feel overwhelmed, fearful, powerless, and fatigued. Family's response is dependent on the type and length of illness, the relationship with the patient. Patient's needs and wishes must be maintained. Patients need time to think and express feelings. Fatigue, weakness, and confusion may increase response time. The time spent in bereavement depends on the number of factors, including how attached one was to the person who died and how much time was spent anticipating the loss. Bereavement and grief counseling is an important aspect of palliative care. Although often used interchangeably, bereavement refers to the state of loss and grief refers to the reaction of loss. Grief occurs in response to real loss as well as what might have been. Psychologic responses including anger, guilt, anxiety, sadness, depression, and despair. Psychologic reactions include sleeping problems, changes in appetite, physical problems, and illness. Grief is influenced by the relationship with a person who has died, whether it's a spouse, parent, or child, physical and emotional coping resources, concurrent life stresses, cultural beliefs, personality, mental and physical health, economic resources, religious influences, and spiritual beliefs, family relationships and conflicts, social support, and time spent preparing for the death. Not everyone experiences all stages and not necessarily in progressive order. Denial may last minutes to months and be characterized by withdrawal. Anger may be focused in any number of directions. The person who inflicted the hurt at the world for letting it happen, at oneself even though nothing could have been done to stop an event from happening like a car accident, bargaining for more time or something other than the death. Depression may be expressed in numbness, anger, or sadness. Admitting the reality of the loss results in a calmer phase known as acceptance. Table 9-4 describes Kubler-Ross's model of grief. After a person experiences the loss, there is shock, numbness, denial, inability to think straight. Then comes the protest stage, where a person experiences anger, guilt, sadness, fear, and searching. Then comes the disorganization stage, where one feels despair, apathy, anxiety, and confusion. The next stage is reorganization, where a person gradually returns to normal functioning, but he or she feels different. Then the final stage is the new normal. Eventually, the destabilization experienced in grief will resolve, and a normal state can begin. Because of the loss, the normal state is not the same as before. The challenge is to accept the new normal. Trying to go back to the old normal, which is not there anymore, is what causes a great deal of stress. Anticipatory grief was when caregivers of patients with chronic illness often begin to grieve long before the actual death. Adaptive grief is working in a positive way through grief process, helps to adapt to the loss. May occur before death actually occurs or when death becomes inevitable. Dysfunctional grief, physical and psychological impact of a loved one's death may persist for years. Prolonged grief disorder was formerly called complicated grief. Estimates indicate 1 in 5 bereaved individuals experiences prolonged grief disorder, at greater risk for illness, work, and social impairment. Bereavement and grief counseling are core components of patient and family-centered palliative care. The grieving process takes time, energy, and work. The process of resolution in normal grief may take months to years. Grief counseling facilitates discussion of feelings and cultivates an environment for open expression of all feelings, anger, fear, and guilt. Respect for privacy and desire to talk or not talk is important. Honesty in answering questions and giving information is essential. A person may be of no particular faith but have deep spirituality. Some patients may choose to pursue a spiritual path. Some may not. Their individual choice needs to be respected. The patient's and family's preferences related to spiritual guidance or pastoral care services should be assessed and appropriate referrals made. Questions to guide spiritual assessment can be found on Table 9-7. Deep-seated spiritual beliefs may surface when patients deal with their terminal diagnosis and related issues. Some dying patients are secure in their faith about the future, experience decreased despair at the EOL, may relinquish material possessions, focus on values they believe will lead them on to another place. Religion may provide order to the world even in the presence of physical decline, social losses, suffering, and impending death. It may offer existential meaning that provides peace and recognition of one's place in the broader cosmic context. Characteristics of spiritual distress include anger towards God or higher being, change in behavior and mood, desire for spiritual assistance, or displaced anger towards clergy. Culture and ethnicity are important considerations for patients who are receiving palliative and EOL care and their families. In some groups, death and dying are private matters shared only with significant others. Feelings are often repressed and internalized. Beliefs include toughing it out and being strong. Some groups, African Americans and Hispanic Latinos, easily express feelings and emotions. Kinships are very strong in Hispanic cultures. Both immediate and extended family provide support. Expression of feelings is encouraged and accepted. Some groups are less likely to use palliative or hospice care in general. African Americans value toughness in times of hardship and use hospice care less often. Spouses and daughters are involved in Hispanic decisions. Families decide if terminal diagnosis, life support, and withholding treatment should be discussed with the patient in Filipino American cultures. Jewish Americans believe the spirit should not be alone when it leaves the body, so keep constant vigil and expect all body tissues to be buried with the individual. Puerto Rican Americans may want to kiss and touch the body after death to say goodbye. Perceptions, such as giving up, need to be clarified through open discussion about philosophy in hospice and palliative care. Rituals associated with dying are part of all cultures. In certain cultures, the family may want to keep constant vigil in the room of a dying patient or in the waiting area. For example, some Jewish Americans believe that the spirit should not be alone when it leaves the body at the time of death. Therefore, someone who is terminally ill should never be left alone. The Jewish culture believes all body tissues must be buried with the individual. Once death has occurred, some cultures, such as the Puerto Rican American culture, may want to kiss and touch the body to say goodbye. In Islamic cultures, the tradition rites of washing, shrouding, funeral prayers, and burial are done as soon as possible. Families with non-English speaking members are at risk for receiving less information about their family member's critical illness and prognosis. Cultural variations also exist in symptom expression, such as pain expression, and use of healthcare services. Providing culturally competent care requires assessment of nonverbal cues, such as grimaces, body position and decreased or guarded movements. Cultural variations in use of services and symptom expression, including pain, exist. Culturally competent care requires greater attention to nonverbal cues, such as grimaces, body position and decrease or guided movements, individualized assessment of suffering, early input from patient and family for care before death and care of the body after death, avoiding stereotypes, suggesting grief and bereavement counseling for the family, accommodating language, diet, and cultural beliefs and practices, using medical interpreter services when indicated. Decisional capacity refers to the ability to consent or refuse care. It means that the individual has an understanding and appreciation of the information that is shared and has the capacity to engage in the reasoning process. Provide information so that care outcomes are based on the wishes and values. Organ donation can be made by legally competent persons, can be made by immediate family following death, can be specified on donor cards or, in some states, on driver's license. It's handled by various agencies that differ by state and community. It follows specific legal guidelines for organ and tissue donation. And some tissues must be used within hours after death, so require immediate physician notification. In Ohio, we use LifeBank for organ donation. The first advance directive was called a living will. Most states now have natural death acts that may include directives to physicians or DTPs, durable power of attorney for health care, medical power of attorney for health care, Unique requirements vary by state, but allow an individual to tell the physician exactly what treatment is or is not desired. Copies of forms can be obtained from the internet and local medical associations, but are not required. Verbal directives can be given to physicians in the presence of two witnesses. The physician may use a physician order for life-sustaining treatment or a medical order for life-sustaining treatment to outline current treatment options that honor the person's requests. Patient retains a copy of the order to be used in an emergency where the primary physician is not available for consultation. Attorneys and notaries may not be required in the development of these directives. A surrogate decision maker, usually family or significant other, determines measures of care when the patient is not capable of communicating with them. Often nurses and other medical professionals do not know who can legally make EOL decisions for patients when they no longer have decisional capacity. CPR is given for respiratory or cardiac arrest unless otherwise ordered by a physician. However, whether and to what extent CPR is used is no longer the sole decision of the physician. The ANA supports patients' right to self-determination, and primary role of nurses is supporting patient and family decisions. Full code refers to the use of complete and total heroic measures, including CPR, drugs, and mechanical ventilation. Chemical code involves use of drugs without CPR. DNR indicates comfort measures only, without interference of technology. Some states have out-of-hospital DNR for patients being cared for out of acute care facilities. Term being used to replace DNR is AND, allowed natural death. More accurately conveys what actually happens. Also referred to as comfort measures only status. Comfort measures include pain control and symptom management. Natural progression to death is not delayed or interrupted. Care is not withheld. Care is supportive, providing comfort and dignity while allowing nature to take its course. You need to be aware of legal issues and the patient's wishes. Advance directives and organ donor information should be located in the medical record and identified on the patient's record and or in the nursing care plan. All caregivers responsible for the patient need to know the patient's wishes. Additionally, you are responsible for becoming familiar with state, local, and agency procedures in EOL care documentation. According to the ANA, nurses should not participate in active euthanasia because it is in direct violation of the code for nurses, the ethical traditions and goals of the profession, and its covenant with society. Physician-assisted suicide is legal in 4 states. In this case, the physician provides the means and or information about how the patient can commit suicide. As a nurse, you have an obligation to provide timely, humane, comprehensive, and compassionate EOL care. Euthanasia should not be confused with palliative sedation, which is the use of medications to intentionally produce sedation in order to relieve intractable symptoms and distress in a patient who is imminently dying. The intent of palliative sedation is to relieve pain and suffering, and not to shorten life or to hasten death, as is the case with euthanasia. The use of opioids for symptom management at the end of life is often misunderstood and feared by patients, families, and healthcare providers. For this reason, many patients will refuse to take the medications, which leads to physical and emotional suffering due to uncontrolled pain and symptoms. Your moral obligation to relieve suffering, which includes giving medications that have the potential of producing harm, such as opioids. The principle of double effect refers to the principle that regards it morally permissible to give a medication that has the potential for harm if it is given with the intent of relieving pain and suffering and not intended to hasten death. As a nurse, your role is to teach the patient and family regarding addiction, tolerance, and dependence to medication. The person with terminal illness should not be concerned with addiction when the goal of treatment is comfort. Nurses need to recognize their own needs when dealing with grief and dying. Nursing care of terminally ill and dying patients is holistic and encompasses all psychosocial and physical needs. Although there is no cure for the person's disease, the treatment plan still consists of assessment, planning, implementation, and evaluation. The main difference is that the focus of care is on management of symptoms of the disease, not necessarily the disease itself. Be sensitive. Do not impose repeated, unnecessary assessments. Use medical record data rather than tiring patient with interview questions. Specific events or changes that brought patient in should be documented. The patient's medical diagnosis, medication profile, and allergies are recorded. Promptly address discomfort. Use evidence-based tools for symptom assessment, including numeric scales or visual analog scales for pain rating. Evaluate and manage comorbid health care problems. Gather information about abilities, intake, rest, and general response to the terminal illness and its prognosis. Determine the family's ability to manage and cope with the needed care and the consequences of the illness. Physical assessments are abbreviated and focused on change that accompany terminal illness. Assessment may occur weekly for patients cared for in their homes by hospice programs. In the final hours of life, physical assessment may be limited to essential data. Key elements of social assessment include family relationships, communication patterns, differences in expectations, interpersonal conflicts that may result in family disruptions during the dying process and after death, and patient and family goals. Multiple systems often fail during the EOL period. Neurologic assessment is especially important. So you want to assess for the LOC, presence of reflexes, pupil responses. Evaluate changes in circulation by doing vital signs, checking the skin color and temperature. Monitor and describe respiratory status, such as the character and the pattern of respirations and breath sounds. Monitor I's and O's, nutrition and fluid intake, urinary output, bowel function for renal and GI functioning, ongoing condition of fragile skin that can be easily broke down. It is important to note that in the last hours of life, assessments should be limited to only those that are needed to determine patient care comfort. Assessment of pain and respiratory status may be the most important during this time. It may be more peaceful and comforting to the patient and family to refrain from overstimulation that may occur from certain types of assessments, such as measuring BPs or checking for pupillary response. As death approaches, your efforts may be better spent providing emotional support to the patient and the family rather than performing tasks that will have no impact on the patient's physical care. Family conference may be helpful. Develop a comprehensive plan to support, teach, and evaluate patients and their families. Nursing care goals may include determining where the patient would like to die and whether this is possible. For example, the patient may want to die at home, but the family may object. Many factors contribute to the patient and the family's decision. Interprofessional EOL care that includes the physician, social worker, chaplain, as well as many other members of the palliative and or hospice care team is important. Consult palliative care specialists for dealing with sudden or traumatic deaths, such as those that occur in the ICU. Teaching of patient and family on how to cope with the many issues during this period is important. See Table 9-7 for psychosocial manifestations at the end of life. Anxiety is an uneasy feeling whose cause is not easily identified, frequently related to fear, and managed with medications and non-pharmacologic interventions like relaxation breathing, muscle relaxation, music, and imagery. A grieving person cannot be forced to accept the loss. Surviving family members may be angry with dying loved one who is leaving them. You may sometimes be a target of anger and must understand what is happening and not react on a personal level. Encourage expression of feelings at the same time realizing how difficult it is to come to terms with a loss. Feelings of hopelessness and powerlessness are common during EOL period. Allow patient and family to deal with what is within their control and help them recognize what is beyond their control. Four specific fears are pain, shortness of breath, loneliness and abandonment, and meaninglessness. Many people assume that pain always accompanies death. Terminally ill patients who do experience physical pain should have pain-relieving drugs available. Assure the patient and family that drugs will be given promptly when needed and that side effects of drugs can and will be managed. Reassessment of pain after medications are given is an important nursing action. Patients can participate in their own pain relief by discussing pain relief measures and their effects. Most patients want their pain relieved without the side effects or grogginess or sleepiness. Pain relief measures do not need to deprive the patient of the ability to interact with others. Respiratory distress and dyspnea are common near EOL, end of life. Anxiety-reducing agents may help produce relaxation. Most terminally ill and dying people fear loneliness and do not want to be alone. Many dying patients are afraid that loved ones who are unable to cope with the patient's imminent death will abandon them. Holding hands, touching, and listening are important nursing interventions. Fear of meaninglessness leads people to review their lives. Life review helps patients recognize the value of their lives, assist patients and their families in identifying the positive qualities of the patient's life. Practical ways of helping may include looking at photo albums or collections of important mementos. Sharing thoughts and feelings may enhance spirituality and provide comfort for the patient at this time. Respect and accept the practices and rituals associated with the patient's life review while remaining non-judgmental. Empathy is identification with and understanding of another's situation, feelings, and or motives. Active listening is paying attention to what is said, observing nonverbal cues, and not interrupting. Silence may be related to overwhelming feelings experienced at the end of life. It can allow time to gather thoughts. Listening conveys acceptance and comfort. Consider ethnic, cultural, and religious backgrounds. Patients and families may have difficulties expressing themselves emotionally. Make time to listen and interact in a sensitive way to enhance the relationship among you, patient, and family. A family conference can create a more conducive environment for communication. Prepare family members for changes in emotional and cognitive function that occur at end of life. Unusual communication may take place. Patients may speak to or about family or others who have predeceased them, give instruction to those who survive them, speak of projects yet to be completed. Listen carefully. That helps identify specific communication patterns. And it decreases the risk for inappropriate labeling of behaviors. Physical care, see Table 9-8 for more information. Physical care focuses on the needs for oxygen, nutrition, pain relief, mobility, elimination, and skin care. Skin integrity is difficult to maintain at the end of life because of immobility, urinary and bowel incontinence, dry skin, nutritional deficits, anemia, friction, and shearing forces. If possible, it is important to discuss with the patient and family the goals of care before treatment begins. An advance directive should be completed so that the patient and family's wishes are followed. Consideration must be given for cultural customs, state law, agency policy, and procedure. May be important to allow family to prepare or assist in preparing the body in some cultures and some types of death. Remove tubes and dressings if appropriate. Straighten the body, leaving the pillow to support the head and prevent pooling of blood and discoloration of the face. In the case of unexpected or unanticipated death, preparation of a patient's body for viewing or release to a funeral home depends on state law and agency policies and procedures. Never refer to the deceased person as the body, quote unquote. Care of and discussion related to the person should continue to be respectful even after death. Family caregivers are important in meeting patients' physical and psychosocial needs, often face high levels of stress and emotional, physical, and economic consequences from caring for a dying member. Responsibilities do not end when the person is admitted into an inpatient facility. An understanding of the grieving process for patient and family caregivers is important. Being present during a family member's dying process can be highly stressful. Caregivers at higher risk have concurrent life crises, such as divorce. Abnormal grief reactions may include dependency, negative feelings about the dying person, inability to express feelings, sleep disturbances, history of depression, difficult reactions to previous losses, perceived lack of social or family support, low self-esteem, multiple previous bereavements, alcoholism, substance abuse. Family caregivers and other family members need encouragement to continue their usual activities as much as possible. They need to discuss their activities and maintain some control over their lives. Inform caregivers about appropriate resources for support, including respite care. Resources such as community counseling and local support may assist some people in working through their grief. Encourage caregivers to build a support system of extended family, friends, faith community, and clergy. The caregivers should have people to call on at any time to express any feelings they are experiencing. Many nurses who care for dying patients are compassionate about providing quality EOL care. A bond or connection may develop between you and the patient and or family. Be aware of how grief personally affects you. When dealing with death and the dying, you are not immune to feelings of loss, helplessness, and powerlessness. Express feelings of sorrow, guilt, and frustration. Recognize your own values, attitudes, and feelings about death. Be aware of what you can and cannot control. Realize it is okay to cry with the patient or family. Focus on interventions to decrease your own physical or emotional stress. Get involved in hobbies or other interests. Schedule time for yourself. Maintain a peer support system and develop a support system beyond the workplace. Hospice agencies can provide care for their team with professionally assisted groups, informal discussion sessions, and flexible time schedules. Another question: the hospice nurse visits with the wife of a dying patient. The nurse is most concerned if the patient's wife makes which statement? Go ahead and read the responses. And what answer do you think it is? That's right, it's A. The rationale here is normal reactions to loss include the statements in options B, C, and D. Option A indicates an abnormal grief reaction and possible suicidal thinking.